The third subject which we are going to start is ophthalmology. That obviously we are going to equally important, that is ophthalmology. Aankhon wala. Let's talk about the ophthalmology. In ophthalmology, the first thing we have to start with the anatomy. Anatomy में different structures are there. So we have divided basically eye into three parts. What are those, sir? Outer, which is cornea, middle, which is also called as outer layer, middle layer, and inner layer. Sir, outer layer we are having cornea, sclera, limbus. This cornea is the only avascular structure in the eye. Cornea is the only avascular structure in the eye. Sclera is a white part in the eye, and limbus having the muscles, zonules and ciliary muscle, which are for the mydriasis and meiosis of the eye, plus also for the accommodation power of the eye. Then middle layer we are having uvea, and uvea is having three structures. What three structure uvea is having? ICC. What three structure uvea is having? ICC. ICC stands for iris, ciliary body, and choroid. My dear friends, this iris will decide the color of the eye. This iris will decide the color of the, and ciliary body is having pars pliccata and pars plana. They are responsible secretion of aqueous humor. Aqueous humor. We are having two type of fluids in the eye. One is aqueous humor. The choroid is the most vascular structure in the eye. So because of the most vascular structure in the eye, the choroid is responsible for the thermoregulation of the eye. Thermoregulation of the eye. So these are some basic things you should know before starting the eye part. Now let's talk about the three layers. We have talked about the outermost layer is having cornea, then sclera, then limbus, then middle is having uvea. Uvea is having three structures. ICC, that is iris, ciliary body, and choroid. And other than that, we are having the inner structure where we are having the main retina, my dear friends. The basic one-liners we have to remember, we have to focus on. Volume of orbit is 30 ml. Yes, we agree to that. Full of the orbit we are talking about. If we have to talk about only eyeball, it is 6 ml. Out of 6 ml, 4 ml is who? Who is 4 ml? Vitreous humor is 4 ml. Who is 4 ml? Vitreous humor is 4 ml. Now there is an MCQ which we have learned in the ENT also. Orbital blowout fracture. The most common wall which is going in the orbital blowout fracture. This is CT scan, coronal section we are having. This is a teardrop sign. Teardrop sign. And we have, remember, the mnemonic DI. D for diplopia, I for infraorbital anesthesia. Wherever the punch is going to go, there will be a numbness. This is called as infraorbital anesthesia. Then anophthalmos. The eye is going to go inside. Diplopia can happen, anophthalmos can happen, and also in infraorbital anesthesia can happen in a orbital blowout fracture. Multiple time asked question in the exams. Now coming to the next is cornea. Cornea is an avascular structure, is present on the outer side. This avascular structure is responsible for bending of the light. Bending of the light. Very important. And this is a transparent avascular structure. Now thickness and curvature is measured with the help of MCQs. Now if we are talking about the thickness, we are talking about the packing. More packing, more thickness, like where we are wearing the clothes, more packing. So packing, thickness, it is pachymetry. The test which is done to check the thickness of the cornea, that test is called as pachymetry. That test is called as pachymetry. And for the curvature, we are having keratometry, and we are using a specific device for that, and that is called as Placido disc, my dear. The blue color you are seeing right here is Placido disc. Now coming to another thing, refractive index. The refractive index of a air is 1, cornea is 1.37, and length is a previous year question. PYQ. Lens in the center we are having 1.40, periphery we are having 1.38. So in the lens it is from 1.38, right, starting from periphery going to the center, that is 1.48. That is for the center of the lens, which is having the maximum refractive index of 1.40. Air 1 straight away, cornea 1.37, lens it is 1.38 to 1.40. Where is maximum? Your answer is going to be, it is in the center. And how much it is? Your answer is going to be 1.40. Now let's talk about this uvea. We have already talked about iris. What is going to do? Iris is going to decide the color of the eye. Iris is going to decide the color of the eye, sir. Color of the eye. Ciliary body. I told you ciliary body is having two structures. What two structures? Pars plicatum, pars plana, and they are helping in what? Your MCQ was they are helping in the production of aqueous humor, sir. They are helping in the production of aqueous humor. Aqueous humor. Now coming to the next one is choroid. Choroid we have already learned it is the most vascular structure in the eye, drained by vortex vein. And because most vascular supply is coming, so your thermoregulation is also taken care by the choroid, sir. Thermoregulation is also taken care by the choroid, my dear friends. Choroid, my dear friends. Then coming to the retina. Retina is the innermost layer from where the optic nerve is connected and the visual signals are going to the visual area, which is area 17, 18. Done. Now, ora serrata is the thinnest part of retina. Ora serrata is the सबसे पतलू part of the retina, and center of retina is having special type of structure. A central of retina is having special type of structure. What are those? Macula, fovea, optic disc. Now, fovea is sounding like a PHOBIA phobia wala. So remember, fovea is most sensitive to light. The structure of the retina which is most sensitive to light, your answer is going to be the fovea. Your answer is going to be the fovea. Optic disc diameter is very, very important. How much it is? 1.5 mm. If there is an optic disc diameter increases, there will be blurring of vision, and we are going to talk about those diseases where you are going to encounter such problems, my dear friends. Such problem, my dear friends. Now let's talk about the cells which are present inside the eye. Those are rods and cones. Two types are there, sir. Rods are of one type, cones are of three types. Rods are of one type, cones are of three types. One type, they are present in the periphery, and what they are responsible for? Your scotopic vision. What is your scotopic vision? That is your black and white vision. Black and white vision. Black and white vision. And what about the photopic vision? The photopic vision is by the cone. How much they are? They are three in number. Oh, sorry, they are three types. They are of three types. Sir, they are red, RGB, red, green, blue, and they are present in center. So colorful vision is by cone and black and white vision is by rods. So total two type of cells are there, rods and cones, rods and cones. My dear friends, first cell to receive light will be rods and cone. And my another question is, which is most sensitive to light? Then your answer should be in the chat box right now, sir. If I ask you most sensitive to light, then your answer should be different, sir. Then your answer should be different, sir. Now, coming to the lens and pupil, what they are dividing? There are chamber, there are segment in the eye. Yes, there are chamber, there are segment. First is fovea. Sensitive to light is fovea, and first to receive is rods and cones. Yes. Now, the lens and the pupil, what they are dividing? So, sir, if you see right here, your lens is sounding like a length. So length is dividing anterior and posterior segment. So length is in segments. Your pupil is sounding like a people. People are sitting in chamber. The pupil is dividing anterior and posterior chamber. They are dividing anterior and posterior chamber. Then coming to the aqueous humor, it is produced by who? Your ciliary body. Pars plicatum plus pars plana. More is pars plicatum. They are secreting that. Now, production rate is 2.5 microliter per minute and outflow rate is 0.2 milliliter per minute of mmHg. And my dear friends, remember something right here. If this flow is reduced, then intraocular pressure is going to increase. And if your intraocular pressure is going to increase, so my dear friends, remember there is going to be a disease, and that disease is called as another MCQ of your exam, that is called as glaucoma. That is called as glaucoma. Now coming to the vitreous humor, which is again a larger structure in the eye with the volume of 4 ml. With the volume of 4 ml. So out of 6 ml, 4 ml is vitreous humor. Is it produced throughout the life? Your answer is no. It is not produced throughout the life. It is present by birth itself, my dear friends. It is present by birth itself, my dear friends. So vitreous humor is present by birth. 98% water and 2% hyaluronic acid is there. 2% hyaluronic acid is there. Total volume is 4 ml, sir. Largest structure in the eye, sir. Now question is, aqueous and vitreous both are responsible for the intraocular pressure, my dear friends. Both are responsible for the intraocular pressure. Let's talk about the power. Eye is having 60 diopter of power, cornea is having 43, lens is having 19 diopter of power. What is the normal axial length of the eye? The normal axial length of the eye is 24 millimeter, my dear friends. But what happens at the time of birth? At the time of birth, this axial length is only 16 mm, which makes our eye small. And small eye is called as hypermetropic eye, and hypermetropia means far-sightedness. So जब बच्चा पैदा होता है, when the child is born, we can only see far. This is called as physiological hypermetropia, which is present by birth. Physiological hypermetropia. So sir, normal axial length of adult, and see, if the axial length is exceeding 24 mm, then it will lead to big eye. Big eye is called as myopia. Big eye is called as myopia. Then the nerve supply of the eye, parasympathetic, sympathetic both. Parasympathetic will lead to the meiosis and sympathetic will lead to mydriasis. Yesterday only I taught you one concept in this. If parasympathetic is there, so every activity which is abdomen and below abdomen is going to increase, and sympathetic above abdomen it is going to increase. So sympathetic above abdomen eye size is going to increase, called as mydriasis, and below abdomen, if we are talking about parasympathetic, above abdomen everything is going to decrease, that it is going to cause the meiosis, sir. The normal vision is 6/6, max possible is 6/3, and we will talk about how to test the vision, my dear friends. The next question is how to test the vision. Sir, testing vision, number one is Snellen's chart. Which chart we are going to talk about, sir? Snellen's chart. This is most commonly used chart. The most commonly used chart is going to be Snellen's chart. Then for the illiterate people, sir, for the illiterate people, we are having a landlord's link. Like if we say landlord people are illiterate people, they don't know how to read. For these people, we are having ring. कि मुंह कहाँ से खुला, where the opening is, up, down, lateral. This is how they will tell you. Then Allen's chart is there for the preschool children. They can identify the shapes. And the children who are not able to speak, mostly less than 2 years or 1 year, optokinetic drum is there. Here we'll check the nystagmus, the movement of the eye. Moment we roll the drum and the eye movement is not there, that means baby is not able to see. And if movement is there, that means baby is able to see. Baby is able to see. Baby is able to see. Now next is best chart to check the vision, and that is going to be EDTRS or Logmar chart, sir. EDTRS or Logmar chart. EDTRS or Logmar charts. EDTRS or Logmar chart. So my dear friends, EDTRS or Logmar chart is like a sloping thing. So most common used chart will be, my first question, the most common used chart is going to be, then your answer is going to be, the most common used chart is going to be Snellen's chart. And best chart is Logmar chart. Other name of Logmar chart is ETDRS chart. ETDRS chart. ETDRS chart. Very, very good. Very, very nice. Now, अब chart से check कर लिया, chart में नहीं दिखाई दे रहा, then what you will do next? Finger count. If finger count is also not visible, you will wave the hand. If waving of hand is also not visible, then you will go for the torch. You will put torch in the eye. If still light is also not visible, then we consider that person is blind now. Then this person is blind now, sir. Now, let's talk about the next thing which we were talking about is intraocular pressure, sir. We were talking about intraocular pressure. Ladies and gentlemen, it is a pressure exerted by both aqueous and vitreous humor. Aqueous and vitreous humor both are responsible. Normal is 10 to 21. If it is more than 21, called as glaucoma, and it is measured with the help of device, and which is previous year question of your exam, sir. This intraocular pressure is measured with the help of device, which is your best device to measure the intraocular pressure, and the best device is again exam question, that is Goldmann applantation. Goldmann applantation. Visual field, let's talk about. Sir, if I talk about male or female, who is having the better visual field or bigger visual field? Your answer should be female. And why so? God has graced them like that. So visual field we have to talk about. So superior, inferior, nasal and lateral. So my dear friends, if we compare, lateral is having the widest range. Lateral is having the widest range, my dear friends. So here you will see superior and your nasal is same 60, inferior is 70, and your lateral is 100. And how to check? In the bachpan also, in the early childhood, we have seeing through the machine, and where one balloon is there, house is there, green grass is there, they are asking kya kya dikh raha hai. So on the basis of that, they will decide our visual field is normal or not. And remember, that is called as none other than Humphreys perimeter. That is called as none other than your Humphreys perimeter, sir. Now next topic what we are going to talk about is color blindness. It's a X-linked recessive. That means females are carrier but never affected. Female carry तो करती हैं पर affect नहीं होती हैं. Now the person is confused. Color blindness doesn't mean that there is a complete absence of, जैसे कि लाल पड़ा दिखाई नहीं दे रहा उसके पूछा. The person is confused for color. This is called as color blindness. So my dear friends, proto is for red color, deuter is for green color, trito is for blue color. So if the word normal is there, that means there is a weakness of the cone. So red cone is weak. Deuter normally matlab green cone is weak, and trito normally matlab blue cone is weak. If the word is protonopia, that means absent. Normally means weakness, nopia means absent. Nopia means absent. And what is monochromatism condition, my dear friends? Monochromatism is a condition where only rods are present. And my dear friends, I taught you that if only rods are present, that means the person is seeing the world black and white. The person is seeing world as black and white. He or she will not able to see world as what? He will not able to see world as colorful world. So उसकी दुनिया कैसी हो जाएगी? 50 shades of. चलो, done. Now coming to the color blind checking, the investigations are 𝗖𝗵𝗆. The most common one is what are your 𝗖𝗵𝗆. You can see different numbers in this. We have to see. If you are not able to see, that means we have the color blindness. Color blindness. Another test is FMGE. Another test which is the best test which was asked in the previous exam, and this is Naegele's anemaloscope. Naegele's anemaloscope. Naegele's anemaloscope. Now coming on to the next thing, that is your ocular movement. The muscle which are helping in the opening of the eye and muscle which is helping in the closing of the eye. Opening of the eye require at least 3 muscles. Opening of the eye required at least 3 muscles. What are they? LPS, levator palpebrae superioris, molars and frontalis. Closing only requires orbicularis. Then one mnemonic you have to remember: synrat, superius intort, and your rectus adduct. And another mnemonic is SO4LR6. LR6. Superior oblique is supplied by 4th nerve, lateral rectus is supplied by 6th nerve, rest all are supplied by 3rd nerve. Rest all are supplied by 3rd nerve. So let's talk about the muscle arrangement right here, sir. Focus. How the muscles are arranged. So my dear friends, right here, medial side mein there is a medial rectus, lateral side mein lateral rectus. If you see right here, so this is right eye, this is left eye. So lateral side pe lateral rectus, medial side mein medial rectus. Right side पे lateral side पे inferior में is a inferior rectus. There you have to focus. अब इसके side पे सर आप बोलोगे there should be inferior oblique. This is the catching word you have to remember in case of eyes. Inferior rectus के बगल में you are going to have a superior oblique, and opposite will happen onto the other eye and the same eye. Inferior rectus नीचे है, ऊपर is going to be superior rectus. Superior oblique नीचे है, going to be the inferior oblique. And opposite will happen lateral side के नीचे, left वाले के lateral side inferior rectus, opposite superior oblique. Then this is how. Then we ever talk about SO4LR6. The superior oblique is supplied by 4th nerve, rest everything, and the lateral rectus is supplied by 6th nerve, rest everyone is supplied by 3rd nerve. 3rd nerve, sir. Done, sir. Now coming to the question, what are their individual actions? So write down like this: SR, IR, SO, IO. Superior rectus, inferior rectus, superior oblique, inferior oblique. So intorsion, extorsion, intorsion, extorsion. In X, in X. पहला सीक्वेंस क्या बना? In X, in X. Then दूसरा सीक्वेंस बनता है add, add, abduct, abduct. पहला in X, दूसरा है add, add, abduct, abduct. तीसरा है elevation, depression, depression, फिर elevation. Elevation, depression, depression, फिर elevation. तो एलिवेशन डिप्रेशन. अब इसको 3 हिस्सों 4 हिस्सों में डिवाइड कर दीजिए. सुपीरियर रेक्टस इज हैविंग दिस फंक्शन, inferior rectus having this function, superior having this function. With this trick you can solve all this question in your exam. Now binocular single vision. What is this binocular single vision, my dear friends? Binocular single vision is we are having two eyes but still we are able to see only one image. How? First of all, three grades we are dividing it into. What are the three grades what we are dividing into two? One is simultaneous macular perception. Then there is a fusion of the image. Then third is stereopsis, that is depth perception. Till here we are getting the 2D vision, but stereopsis is 3D, which is the 3D vision. And to check this binocular single vision, and we are having a test called as 𝗃𝗵𝗵𝗴𝗿 test. This stereopsis, we have a 𝗃𝗵𝗵𝗴𝗿 test. 𝗃𝗵𝗵𝗴𝗿 test. Anisometropia. What do you mean by anisometropia? Power difference between two eyes is more than 2 standard deviation. That means more than 95%. Can't wear glass. There will be diplopia. Treatment kya doge, sir? Contact lens, sir. Contact lens. Now coming to the cataract topic, another topic which is important for the exam, and that is a cataract topic, sir. Sir, cataract, opacification of the lens or capsule. Opacification of the lens or capsule. Most common cause of blindness is cataract. Second most common is glaucoma. Infectious is trachoma. In children, it is vitamin A. Ocular morbidity, refractive error, sir. What is the definition of the blindness? The WHO says less than 3/60 with best possible correction in better eye. This is a complete definition of a blindness, was asked at the exam previously also, sir. Now we have divided into three type of blindness. ESM, like we study PSM, here we study the PSM. Sir, a very simple to remember: economic, social and manifest. It is 6/60, 3/60, 1/60. So less than 6/60 is economic, less than 3/60 is social, and less than 1/60 is manifest. Less than 1/60 is manifest. Now my question is, if the vision is 2/60, we consider that as which type of blindness? Can you answer me? If the vision is less than 2/60, if 2/60, we consider out of these three, we consider that as which type of blindness? Among these three. So 2/60, less than 3/60, you have to mark answer as social man. Now type of cataract: nuclear, cortical and posterior subcapsular. Nuclear is for day blindness, cortical is for night blindness, and posterior subcapsular is exam question. Posterior subcapsular is for day and night plus near vision. And many times examiner is asking us the question. What question examiner is asking? The examiner is asking, the old man is not able to read newspaper in the bright daylight. That means not able to read newspaper. What does that mean? Near vision is impaired plus bright daylight. This component is there. This fits better into the answer of posterior subcapsular cataract, my dear friends. Now different type of cataracts with their findings. We'll see a congenital ke andar zonular and punctate. Zonular ke andar your other names are laminar and riders also. You are going to see the spokes wheel opacity. You are going to see the spokes wheel opacity. And in the punctate or blue dot, my dear friends, punctate or blue dot, you are going to see this punctate. These are the congenital cataract. Now traumatic blunt trauma, roseate cataract, flower shape appearance, you are going to see. Metabolic cataract, we are having, number one is diabetic. Sir, all the cataract are sudden. All the cataract are slow progressing. Only cataract which is sudden, that is going to be your diabetic cataract. It is snowflake cataract. What is accumulated here? Sucrose plus fructose is accumulated right in the eye, sir. In the eye, sir. Tell you, sir. Wilson's disease. Sir, ATP7B ATP7B gene is involved for the Bilson, B for Bilson. Sunflower like appearance, there is a deficiency. There is a deficiency of ceruloplasmin. There is a deficiency of ceruloplasmin, and ceruloplasmin is a copper transporter. Agar ceruloplasmin nahi hoga, copper will deposit on the different part of the body, and if it will deposit on the eye, you will have a 𝗃𝗃𝗃𝗃 ring, a sunflower type of appearance. Galactosemia, from the yesterday's class, can you tell me which enzyme deficiency we are talking about in the galactosemia, my dear friends? In the galactosemia, which enzyme deficiency Which enzyme deficiency we are talking about? GALPUT. And what we are seeing right here, sir, oil drop cataract. Next is myotonica dystrophica Christmas tree cataract you are going to see, sir. Then symptoms of cataract, slow, painless, loss of vision. Only cataract which is sudden is a snowflake cataract, which is also called as diabetic cataract. Snowflake cataract or diabetic cataract. Sir, patient can have a diplopia, also can have a color halos. For color halos, we are having a different test called as Fincham test. Fincham test we are having, and here the examination is slit lamp examination. You can see an unhappy man and a happy woman. So this is a slit lamp examination. Slit lamp examination. Very, very nice. Treatment of cataract. See, if a young patient is there, we avoid surgery because we require accommodation power in an adult. So that in a young patient, we prescribe glasses. And in the old patient where we do not need accommodation, there we will prefer a surgery. They will prefer a surgery. Now, different type of surgeries, what we have, 𝗖𝗵, 𝗖𝗵, phacoemulsification, and one more surgery is there, femto laser is a flask. Now, sir, 𝗖𝗵 is an intracapsular cataract extraction where capsule and length both are extracted. 𝗖𝗵 where capsule is there and lens is extracted and we put a lens inside. Phacoemulsification is a stitchless surgery where only 3 mm incision is given and foldable intraocular lens is placed in that. One more is femto laser assisted surgery, which is superior to all of them. Flask, sir. Coming on to after operating cataract, what complication we can have, sir? That is also important question equally. What complication we can have, sir? Number one is secondary cataract. How it is visible? We are going to see on the fundoscopy 𝗔𝗵 and 𝗲𝗵. 𝗔𝗵 and 𝗲𝗵. And how will treat? NDACL laser. Cystoid macular edema. What we are going to see, sir? Honeycomb appearance. Honeycomb appearance. Cystoid macular edema. Honeycomb appearance we are going to see, sir. Then, sir, next third complication what we can have is endophthalmitis, is an infection of the vitreous. Now, this is triple V disease. How? There is a loss of vision. Treatment, intravitreal injection of another V, 4V, that is vancomycin. How we can prevent? Cleaning of the eyelashes with the pyridine iodine, that is your betadine, sir. Betadine. So these are the 3 prominent complications regarding the cataract we have studied. Well, now coming on to the next topic, and that is, sir, what called as uveitis. Uveitis, first of all, uveitis is of 3 types: anterior, intermediate and posterior. What structure we have to talk about? Yes, iris, ciliary body and choroid. Ciliary body is having 2 structures. One is pars plana, another is pars plicatum. Pars plana and pars plicatum. So my dear friends, right here in the anterior uveitis, if we have to simply divide anterior, intermediate and posterior, rule out करने के हिसाब से, remember, anterior uveitis is painful, rest 2 are painless. A one-line answer to this confusion. Only anterior uveitis is painless, other painful, other 2 are painless. Simple. Now coming to the anterior, why there is a pain? Why there is a redness? The pain is because of congestion of a circumciliary muscles. So remember, there is a spasm of a ciliary muscle, and sir, pars plicatum is also involved. Most common cause, again a question, idiopathic, but second most common cause is HLA-B27, which will also lead to a disease in orthopedics, back, bamboo spine, ankylosing spondylitis. Other is what's a Ritter syndrome, which is also called as reactive arthritis. What features this reactive arthritis is having? Conjunctivitis, urethritis and arthritis. Along with arthritis, patient is having urethritis and conjunctivitis. That will suggest you of a Ritter syndrome or reactive arthritis. These are coming under what are your anterior uveitis. Now symptoms, as I told you, circumciliary congestion is there. That is why painful loss of vision is there. Because of congestion, there will be a redness. There will be a redness. And sign what you are going to see, the aqueous flare, mutton fat 𝗘𝗵, nodules. 2 type of nodules are there, sir. Irish nodules are there, sir. One is 𝗲𝗲𝗃, which is present on the surface of the lens. And one is 𝗘𝗵, which is present at the margin of the lens. Margin of the pupil margin of the pupil. Another complication what can happen is a synecdoche formation. Anterior synecdoche will lead to a complication A for A, that is angle closure glaucoma. Posterior synecdoche will lead to 2 complications. One is cataract and another is festooned pupil. Sir, what is this festooned pupil? Festooned pupil means there is a distorted shape pupil. Distorted shape pupil is going to, as you can see this diagram also. Treatment, drug of choice is topical steroid. But if there is an acute case, patient is coming to you with a severe pain, so you need to prescribe a 𝗖𝗵𝗵𝗴𝗍 drug. And 𝗖𝗵𝗵𝗴𝗍 drug of choice in children is atropine. And in adult, it is going to be tropicamide or 𝗖𝗵𝗵𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺𝗺 retinitis. What is happening right here? Pars planitis and vitritis is happening right here, and pars plana is involved in this. Remember, most common cause is again idiopathic. Second is sarcoidosis. Most common finding is going to be the floaters. Other finding is snowball and snowbank. Along with the floaters, snowball and snowbank is seen, and loss of vision, painless, as we already told. A treatment is going to be steroid, my dear friend. Posterior uveitis, infectious, non-infectious causes there. Infectious में toxoplasmosis, non-infectious में sarcoidosis. Loss of vision is again there, but painless loss of vision. What other finding? That you are going to see chorioretinitis, where you will see a creamy yellow patches on the fundus, creamy yellow patches. Head-light in fog appearance, which is associated with vitritis. If a vitritis patient is having inflammation of the vitreous, in this case, in the uveitis, vitreous is also involved, then head-light in fog appearance also you are going to see, sir. Treatment, antimicrobial for the infectious, like toxoplasmos, we can give a spiramycin. For non-infectious, we can go with a systemic steroid, my dear friends. Ocular HIV, commonly asked question, sir. Ocular HIV, remember, the most common manifestation, cotton wool spot and soft exudate. Cotton wool spots and soft exudate. Most common infection is 𝗵𝗵 retinitis. 𝗵𝗵 retinitis. Okay. Cytomegalovirus, where you are going to see owl eye appearance. Owl eye appearance. Owl eye. And most common tumor is 𝗵𝗄𝗄 sarcoma. Most vascular tumor. Yesterday also we have studied HHV8. HHV8. Now, on examination in the ocular HIV, what you are going to see? 𝗵𝗵 or brush fire appearance. 𝗵𝗵 or brush fire appearance. You can very well appreciate right here, sir. Moving on to the next topic, sir. Glaucoma. Moving on to the next topic, that is glaucoma. Glaucoma. ऐसा है, एनर्जी कम नहीं होती है. कोई 6 बजे से बैठा है तो वो 10 बजे तक कूद नहीं सकता है. वो थोड़ा सा टाइम लेगा, है ना. ऐसा नहीं अभी दौड़ना शुरू करा तो पूरी रात ही दौड़ते रहेंगे. थोड़ा रुकेंगे, फिर दौड़ेंगे, फिर थोड़ा रुकेंगे, फिर दौड़ेंगे. It's a normal human being behavior, है ना. We can't laugh 24 hours. We can't dance 24 hours, है ना. So sometime we have to study, sometime we have to joke, laugh, etc. है ना. चलिए. So let's talk about this. ठीक है. Glaucoma. Glaucoma, second most common cause of blindness. Is what, sir? Your glaucoma. That intraocular pressure is more than 21 mm of Hg, and it is measured with the help of tonometer. Now my question is, my dear friends, which is the best tonometer? Which is the best tonometer that you have to answer in the chat box. Best tonometer. Which is going to be the best tonometer? Your answer is going to be the Goldman applantation. Goldman applantation. Very good. What is happening? Intraocular pressure high, visual defect हो जाएगा, optic disc damage होने लग जाएगा. And what about the congenital glaucoma, sir? Congenital glaucoma is also called as 𝗵𝗵. The tride is there, sir. Tride is there. Which tride is there? Lacrimation, photophobia, blepharospasm. Lacrimation, photophobia and blepharospasm. This is for the congenital glaucoma. Now we are dividing this glaucoma into two. One is angle closure and one is open angle glaucoma. How they are different? Angle closure, let's suppose it is most common in the female. And open angle, let's suppose male more than female. So open we are thinking about the male, and close angle we are thinking about the female. Now sir, फीमेल की आंखें छोटी छोटी, फीमेल को रंगों का शौक होता है, और फीमेल को जो परेशान करता है फीमेल उसको ब्लॉक कर देती है. द कॉज इज प्यूपिलरी ब्लॉक, सर. द कॉज इज प्यूपिलरी ब्लॉक, सर. एंड कलर हेलोस के लिए विच टेस्ट आई हैव टॉट यू? फिंशम टेस्ट विल डू, सर. हाइपरमेट्रोपिया मतलब आंखें छोटी हो जाती है तो दूर का ही दिखता है, पास का नहीं दिखता है, सर. एंगल क्लोजर ग्लूकोमा में सिम्टम आर पेन, रेडनेस, सडन लॉस ऑफ विजन. आंखें कैसी हो जाती है? पत्थर जैसी हार्ड हो जाती है. shallow anterior chamber, steamy cornea, all those features are there. And Fincham test we do for the color halos. Drug of choice is pilocarpine for the angle closure glaucoma, hypermetropia. Then sir, coming on to the surgical treatment, we are doing laser iridotomy with the help of Nd:YAG laser. And what if there is an acute attack in the angle closure glaucoma? Then the drug of choice is going to be the mannitol. Mannitol. Now open angle glaucoma, male more than female मान के चलते हैं, मेल की आंखें बड़ी बड़ी, myopia, कलर यहाँ पे क्या पता था, कलर रेसिस प्रेजेंट है, trabecular fibrosis हो चुकी है, asymptomatic, and if symptoms are coming, tunnel vision. Patient is complaining, डॉक्टर साहब पहले पेरिफेरी से दिखना कम हुआ, धीरे धीरे टनल विजन हो गया. तो टनल विजन इज अ फीचर ऑफ ओपन एंगल. और ओल्ड एज पीपल आर कंप्लेनिंग कि प्रेस बायोपिक ग्लासेस आर चेंजिंग सो फ्रीक्वेंटली. Here in children, drug of choice is अपना carbonic anhydrase inhibitor, that is dorzola brinzolamide. In adult, we are having alpha 1 analogs. These are अपना latanoprost drug, which is asked in the exam. Then trabeculoplasty, because trabecular fibrosis was there, that is why we will use the argon laser to treat it, sir. So this is the difference between angle closure and open angle glaucoma. Female में होगा तो angle closure, male more common than female होगा तो this is your open angle glaucoma. आंखें छोटी होंगी angle closure glaucoma, open angle में आंखें बड़ी हो जाती है, myopia हो जाता है. Pupillary block is the reason for angle closure glaucoma, and open angle glaucoma is because of trabecular fibrosis. Tunnel vision is a feature of open angle glaucoma. Frequent change in the presbyopic classes is a feature of open angle glaucoma. In an angle closure glaucoma, there is going to be the stony hard eye, steamy cornea, anterior chamber is going to be shallow. So these all are the different sign and finding. You are going to see the angle closure and the open angle glaucoma, sir. Now next topic is neovascular glaucoma. So neovascular glaucoma के अंदर new vessels are there which are obstructing the outflow, and because of that inside there is lot of intraocular pressure. So most common cause to this is diabetes. First of all, if sir stop the neovascularization, and how to stop the neovascularization? One is drug, another is by the surgery. In surgery की मदद से तुम do the fan photocoagulation, but anti-VEGF drug are the anti-angiogenesis drugs also, my dear friends. That is 𝗵𝗲𝗃 Rani. So anti-VEGF drug में 𝗵𝗲𝗃 Rani we are going to learn, sir. Now coming to the optics chapter. What is this optics chapter? Sir, 5 things we are going to read in this: myopia, hypermetropia, presbyopia, index myopia. So all these things we are going to read right now, sir. Myopia, सबसे पहले myopia. Now myopia के अंदर what is happening? Your eye is becoming bigger and normal, and आपका कितना था? 24. Anterior posterior diameter कितना था? Axial length कितनी थी? 24 millimeter. Now it is exceeding 24 millimeter. If your length is your axial length is increasing 1 mm, the power difference is going to be -3 diopter, sir. -3 diopter, sir. Now what is happening? Here the rays are coming, and because of the big eye, now the rays are focusing before the retina. The rays are opening before the retina. Now what you need? You need a lens which is a diverging lens. You need a lens which is a diverging lens, my dear friends. And which is a diverging lens we are having? We are having a concave lens. So we give patient of myopia concave lens. तो यहाँ से फिर rays diverge होंगी, जिसकी वजह से जो है हमारा दिखाई देना possible हो पाएगा. ठीक है. Next is your hypermetropia. Same I taught you. The eye is becoming small. So your normal axial length was 24 millimeter. Here it is decreasing. 1 mm decrease in axial length will lead to a power difference of +3 diopter. Here what is happening? The rays are coming and they are getting converged behind the retina. So you need a lens which is a converging lens. So converging lens में आया convex lens. here it will converge and new rays will be formed. ठीक है, चलो, done. Hypermetropia is done, myopia is done. Now astigmatism, sir, two different foci, one is before the retina, another is after the retina. Such condition was asked in the exam, and here the treatment is cylindrical glass or toric lens. Here the treatment is cylindrical glasses or the toric lenses. Cylindrical glasses or the toric lenses. Then coming presbyopia, loss of accommodation with the age. Bifocal lens we are using. Bifocal, इस तरीके का lens होता है. For the near vision we put on the glabella, and for the near vision we put on the tip of the nose, and far vision we put on the glabella. Coming on to the next part, sir. Now this is something, a mistake which happened, and because of which some part of your forensic medicine, it just pushed right here, sir. So we'll just go to retina. Chalo. Let's talk about the retina, my dear friends, right now. Retina. My dear friends, this retina is having 10 layers. Sir, 9 are neurosensory. 9 are neurosensory, and 10th is pigmentary layer. 10th is what, sir? Pigmentary layer. Pigmentary layer. Pigmentary layer. Pigmentary layer. Okay? Okay? Pigmentary layer. Now retinal detachment is separation of these 9 layer from the 10th layer. Separation of these 9 layer from the 10th layer, that is called as retinal detachment. That is called as retinal detachment. Now what is happening? The patient is coming to you with, Dr. Saab, आंखों के सामने, so curtain like sensation in front of my eye. Floater and flashes are seen. And now on the fundoscopy or retinoscopy, what glow you are going to see? You are going to see gray glow, my dear friends. Gray glow. Once there is a retinal detachment, which type of glow you are going to see? So my dear friends, the name of glow is gray glow. Gray glow. Next is, what types are there of a retinal detachment? So my dear friends, 3 types of retinal detachment is there. So the second type we were discussing about the tractional retinal detachment. The most common cause is malignant melanoma, exudative, we were talking about third one. Malignant melanoma of the choroid, sir, which is the most common ocular tumor in the adult. So which one is in the children now? Ocular tumor in the children, that is your ocular tumor in the children. Retinoblastoma. In the children, it was retinoblastoma. Now, diabetic retinopathy, type 1 diabetes and type 2 diabetes. Sir, type 1 diabetes and type 2 diabetes, if we talk about type 1 diabetes, if insulin dependent wala is happening, retinopathy, when you should suspect? You should suspect retinopathy 5 years, after 5 years, and check every year. If type 2 diabetes mellitus, which is insulin independent, if that is happening, at the time of diagnosis itself, you have to go for the search for the diabetic retinopathy, or you have to test for the diabetic retinopathy. Earliest feature in the diabetic retinopathy, what you are going to have? You are going to have the microaneurysm, and the most specific feature is going to be the neovascularization. So diabetic retinopathy is further divided into non-proliferative and proliferative. In proliferative, yes, there are the blood vessels. New blood vessels are present in the proliferative. So treatment is pan-retinal photocoagulation. No proliferation is there. So new blood vessels are very less. So no new blood vessels. Soft hard exudate, dot blot hemorrhage, flame shape hemorrhage. Previous year question. So dot blot hemorrhage, soft hard exudate, and your flame shape hemorrhage is a part of non-proliferative, and new blood vessels are there where venous engorgement is there, cherry red spot is seen, and also there will be a box in not box in cartilage, that's not feature here. So there new blood vessel, there's a new blood vessel, and treatment is retinal photocoagulation. Vitreous hemorrhage. Now floaters are seen, but flashes are absent. Sudden loss of vision. Now most common cause in adult is diabetes, second most common cause in youngs is trauma, and second is Ehl's disease. Ehl's disease. Okay, now sir, no glow is seen on examination. Can you now tell me, my dear friends who are watching me, sir, guys, please tell me, gray glow is seen in which condition we have talked about? Yes, my dear friends, you have to give the answer. Now, gray glow is seen in, answer दीजिए. अब नया चीज ऐड कर लीजिए. No glow is seen in. No glow is seen in vitreous hemorrhage. What is the treatment of the vitreous hemorrhage? The patient is coming to you. The treatment of the vitreous hemorrhage, retinal detachment. If vitreous humor is there, then vitreous humor, yaad rakhna, vitreous hemorrhage is there, bed rest for 3 months. And after 3 months, if it is not getting resolved, then you will go for the vitrectomy. Now coming to the next is CRVO versus CRAO. Tomato splash appearance, 90-day glaucoma. Most common cause of loss of vision is macular edema. Treatment is anti-VEGF drug. This is CRVO. Central retinal venous occlusion. On the other hand, we are having CRAO, central retinal arterial occlusion. This is an emergency condition. We have to reduce it within 4 hours. If we are not able to, there will be a loss of vision. And on examination, you will see a cherry red spot, box-on-car appearance, boxcar appearance, tram track appearance. These all are feature of CRAO. And how we can reduce it? Ocular massage, and also by reducing the intraocular pressure by giving the mannitol. So this is an image of tomato splash appearance. This is cherry red spot with the boxcar appearance, image of a CRAO, sir. Now retinitis pigmentosa, रात को नहीं दिखता है. It is non-treatable condition but delayable condition. इसका मतलब क्या? उसका मतलब ये हुआ कि आप इसको ट्रीट नहीं कर सकते हो, बट इसको डिले कर सकते हो. कैसे डिले कर सकते हो? योर आंसर इज विटामिन ए. कितना देना? दैट इज आई एम गोइंग टू टेल यू. तो रेटिनाइटिस पिगमेंटोसा रात को, आर फॉर रात, रेटिनाइटिस पिगमेंटोसा रात को नहीं दिखाई देता. और रात को कौन आता है? पापा. पापा को हिंदी में क्या बोलते हैं? आया. आया कौन आया? पापा. आए पापा. बी फॉर बाप, बी फॉर बोन स्पिक्यूल, ए फॉर आर्टरियल एटेन्युएशन, पी फॉर पेल वैक्सी डिस्क, पी फॉर पेल वैक्सी डिस्क. ठीक है साहब. The person can't see at night. Tried we have seen. Gold standard in investigation is ERG, that is electroretinography, sir. Electroretinography, sir. Manshki, thank you so much. Now, sir, treatment part. Can't treat but can be delayed with the help of what, sir? Your vitamin A. How much we can give every day? 15,000 international unit. 15,000 international unit vitamin A we can give every day. And that can delay it, not cure it. Now coming to the most common ocular tumor of the childhood, बच्चों के अंदर retinoblastoma. Which gene? RB1 gene. Which chromosome? 13q14. What it is called as? 13q14. My dear friends, you will see the leukocoria. Leukocoria is nothing but a cat-eye pupil. Loss of vision, yes. Cottage cheese appearance. Hallmark is Flexner-Windsor rosette. Flexner-Windsor rosette you are going to see. Now this tumor can go from eye to the brain. So the primary vision is not a focus, life is focus. That is why primary is save the life. Second, you have to just save the eye ki structure pada rahe, save the eye. Or tertiary, your approach should be save the vision. And cause of death, for which reason we are first saving the life, was your metastasis. It can metastasize to the brain, my dear friend. It can metastasize to the brain, my dear friend. Coming on to the next topic, and that is cornea and conjunctiva. Cornea, conjunctiva. Now, let's first talk about this, the glands, what they are having. Sir, they are having glands. They are having glands, lipid, aqueous and mucin. What they are secreting? They are secreting, mobibian gland is secreting lipid layer, lacrimal gland is secreting aqueous layer, goblet. What they are lubricating the eye. They are lubricating the eye. Sir, dry eyes or keratoconjunctivitis is a disease where these layers are absent, and this is most commonly seen with the old age people. They are complaining of foreign body sensation in the eye. Despite you checking the eye, you will find nothing. Plus you will see the redness in the eye. Can't tolerate fan or AC, symptom worsens in the evening. You have performed a test, my dear friends. You are performing a test, my dear friends, that is rose Bengal dye positive, sir. Rose Bengal dye positive, sir. Rose Bengal dye positive. And tear breakup time is less than 10 seconds. Tear breakup time is less than 10 seconds. And treatment is artificial tear supplementation, that is methyl cellulose. Chali. 𝗲𝗵𝗵𝗴, grading of 𝗲𝗵𝗵𝗴, my dear friends. XN, night blindness. X1A, conjunctival xerosis. X1B is Bitot spot, and Bitot spot is because of which vitamin deficiency? Remember, first name is longer name, that is conjunctival xerosis, and second is X2, that is corneal. Then 3A, 3B, corneal ulcer. Corneal ulcer less than 1/3 is 3A, more than 1/3 is 3B. S is corneal scar, F is 𝗲𝗃𝗃 fundus, and treatment to such condition happening is vitamin A, and whited spot is a deficiency of vitamin A itself. We have learned yesterday only. Now, two type of conjunctival degeneration is a peduncle is the fatty degeneration. You will see a bump right here, and pterygium is a bird wing-like flag. If asymptomatic, my dear friends, so no treatment. If symptomatic, you have to do the excision. Next is coming to the conjunctivitis. Conjunctivitis. Okay? Conjunctivitis, sir. Most common cause is viral. Different type of conjunctivitis we have to talk about right now, sir. Yes, sir. Epidemic keratoconjunctivitis, pink eye, Madras eye, shipyard eye, caused by adenovirus. Viral is most common. हम चश्मा लगा लेते हैं, आंखें लाल हो जाती है. So it easily spreads from one person to another person. ठीक है? So this is a mostly infectious and spreads very fast. Acute hemorrhages. Acute hemorrhagic conjunctivitis, easy way to remember is whenever there is a hemorrhage, we'll go to the Apollo hospital. The causative will be Apollo virus, enterovirus 70. Ophthalmia neonatrum, we have talked yesterday also, sir. Ophthalmia neonatrum is caused by a bacteria called as. Ophthalmia neonatrum is caused by Neisseria gonorrhea, but other causes are also there. That is within 24 hours, 3 to 5 days, and 5 to 14 days. Within 24 hours, it is happening because of the chemical conjunctivitis by the silver nitrate. 3 to 5 days, it is happening because of the Neisseria gonorrhea, and after 3 days, 5 days, that is 5 to 14 days, this is happening because of the chlamydia trachomitis. And now the chlamydia trachomitis is eliminated from India. So chances are less you'll have in this ophthalmia neonatrum. Let's talk about the next disease, that is called as what's your trachoma. So trachoma is the most common infectious disease of the infectious cause of the blindness, caused by chlamydia trachomitis. Triad, we are having redness, watering, and photophobia, but the main important is hallmark and safe strategy. What we follow, those all are the question asked in the exam. Now this is called as sago grain follicles. These are the pits right here called as Herbert pits, and this scarring is called as Arld's line, my dear friends. Now here, the treatment strategy which we follow is a safe strategy, my dear friends. Safe strategy. What is that? Surgery. A for drug of choice, azithromycin, facial hygiene and environmental sanitization. Blanket therapy to prevent other people having this. This is 1% tetracycline ointment. 1% tetracycline ointment, my dear friends. Now WHO grading of trachoma is also important. Fisto, like safe, remember the fisto. What is fisto? Follicles more than 5, infection caused by chlamydia trachomitis, scarring, that is Arld's line, trichiasis means misdirected ileasis, and opacifications you are going to see. Next disease what we have to talk about is spring cataract or vernal keratoconjunctivitis. My dear friends, spring cataract or vernal keratoconjunctivitis is because of the allergic condition. So which season you are going to think of? Spring season. That is why spring cataract. Here you are going to see the cobblestone papillae, cobblestone. You can very well see like cobblestone papillae. Ropey discharge is going to happen from them, sir, and shield ulcers you are going to see, sir. This is shield ulcer you are going to see, sir. Sir, treatment के अंदर sodium chromoglycate, that is a mast cell stabilizer plus topical steroid we have to give, sir. Coming to the next one is cornea. Cornea is having 5 layers. In this, the important is Bowman's layer, which can't repair itself, scar formation. Stroma is for the thickness, and endothelium layer is for the maintenance of the transparency. Okay? Maintenance of the transparency. Now, question comes about the corneal donation. Corneal donation, what it requires, and what is a favorable condition to donate a cornea, how to save it so that further it can be used. HLA matching is required. Your answer is not required. Must donate within 6 hours. And cornea can be preserved after extracting it out. So how? 2 medias are there. They are your exam question. Macaulay-Kaufman we can save up to 96 hours, and Optisol GS we can save up to 14 days. Now what is the normal cells in a living person? That is 3000 cells per millimeter square. But for a donation, it requires at least more than 2000. And what is contraindicated where you will not take? Remember HIV, HSV, hepatitis B. HSV, HIV and hepatitis B, you will not take cornea of these people. Chalo, let's move on to the corneal ulcer. The next topic is what's your corneal ulcer. In this, number one is 𝗏𝗵𝗵, the most painful condition most commonly asked in the exam, my dear friends, seen in the contact lens user. That is why ring shape ulcer is there. Most common cause is a pseudomonas, and most painful condition, drug of choice is 𝗖𝗵𝗵𝗴𝗺 drugs. 𝗖𝗵𝗵𝗴𝗺 drugs. Contact lens user के अंदर ही pseudomonas infect करता है. Bacterial keratitis, most common cause in world is Staphylococcus, in India Streptococcus pneumoniae. You will see a hyphae which is not a fixed hyphae. Treatment is 4th generation fluoroquinolones. On the other hand, fungal keratitis, most common cause for fungal keratitis is aspergillus. Here you will have a finger-like projection, fixed hypopyon, satellite lesion. Treatment is 𝗏𝗏𝗏. Treatment is what's a 𝗏𝗏𝗏. HSV keratitis, dendritic ulcer, HSV1 or HSV2? Your answer is HSV1. HSV1 में से antiviral therapy we are going to give, sir. Sir, non-healing ulcer के लिए क्या करते हो? केराटोप्लास्टी. और अगर छोटी परफोरेशन हो 1 mm की तो साइनोएक्राइलेट ग्लू ओनली वी विल यूज. व्हाट इज दिस केराटोकॉनस? अगर आपके कॉर्निया के सेंटर में हो जाए थिनिंग, जिसकी वजह से योर कॉर्निया विल लुक लाइक दिस इज कॉल्ड एज केराटोकॉनस. Progressive thinning of the center of the cornea will lead to cone-shaped keratocornea. Sign are Munson's Fleischer-Bogot. ट्रीटमेंट में सबसे पहले ग्लास देने की कोशिश करनी, ग्लासेस लगा के, फिर आरपीजी लेंस यूज कर सकते हैं. If not getting resolved, then you will go for keratoplasty. Never ever directly jump to the keratoplasty. Step by step approach should be there. Now let's talk about refractive surgery, sir. Refractive surgery में LASIK. LASIK we can do for the refractive errors, but there is a contraindication, that is keratoconus. If keratoconus is there, the LASIK is contraindicated. LASIK is contraindicated. Sir, now optic neuritis, also called as papillitis. Sir, inflammation of optic nerve, multiple sclerosis is the most common cause. Disc edema is going to see, and the patient is going to complain कि मेरी movement के साथ में दर्द हो रहा है optic neuritis की तरफ. 𝗖𝗵𝗵𝗎𝗮 steroid we have to give. Retrobulbar, behind the optic nerve, optic disc, behind the optic disc there is a optic nerve. अब optic nerve पे inflammation हुई है तो patient is becoming blind and doctor is not able to find anything because it is happening behind the optic disc. So behind optic disc, the doctor is also blind, not able to see the finding, and patient is also blind because behind the optic nerve it is happening. Here again the drug of choice is 𝗖𝗵𝗵𝗎𝗮. Inflammation is happening, steroid दोगे, most commonly it will resolve. Toxic amblyopia. What do you mean by amblyopia? Lazy eye. If eye is lazy, we do the occlusion. जो eye lazy है उससे काम कराएंगे, it will become. Or how it is happening? Smoking, alcohol. Treatment में क्या करेंगे? Antioxidant add करेंगे, vitamin B12 add कर देंगे. This is going to help now, sir. Sir, Argyll-Robertson, which is prostitute people, and Addis tonic. What is the difference between these two? If you see the diagrammatic, upper one is for the Argyll-Robertson and second one is for Addis tonic. Sir, pupil is constricted, here pupil is dilated. Pupil is constricted, here pupil is dilated. Rest everything is same. Accommodation power is present. Accommodation power is present. Here also it is present, accommodation power. Light reflex is absent. Here also light reflex is absent. The only difference is this is constricted, this is dilated. Constricted and dilated. Constricted and dilated, my dear friends. And how to check? Pilocarpine test. Addis tonic. If we put a pilocarpine, the eye, the dilated eye will become normal. The size will become normal, sir. Then coming on to the next in Horner syndrome. Can you tell me what we have studied yesterday in the Horner syndrome? P male. What are the feature of Horner syndrome? P male, that is ptosis, meiosis, anhidrosis, loss of ciliospinal reflex and ophthalmos. Horner syndrome के लिए टेस्ट कौन सा किया जाता है? कोकीन टेस्ट. तो कोकीन क्या करेगी? डायलेट करेगी. तो इसमें हॉर्नर सिंड्रोम में मियोसिस हो रही है. आफ्टर गिविंग कोकीन द आई विल डायलेट. So abnormal eye will become normal, and abnormal eye will become normal, and normal eye will be dilated. Normal eye will be dilated. Papilloedema, disc edema, raised intracranial tension, worse headache, projectile vomiting, sixth nerve paralysis is seen. Vision is normal. Enlargement of blind spot is seen. Treatment is acetazolamide. Papilloedema. Now visual field defect we have to talk about, sir. Visual field defect, yes. विजुअल फील्ड डिफेक्ट, ऑप्टिक नर्व पे लीजन हो जाए तो मोनोकुलर ब्लाइंडनेस, एक साइड दिखेगा एक साइड नहीं दिखेगा. सेकेंड इज, हाँ मूड फ्रेश करता हूं अभी तुम्हारा, ऑप्टिक 𝗶𝗵𝗎. बाइटेम्पोरल हेमिनोपिया, यू कैन वेरी वेल से लेटरल साइड नहीं दिख रहा है। ऑप्टिक ट्रैक्ट पे अगर लीजन हो जाए, होमोनिमस हेमिनोपिया, एक साइड का मीडियल साइड, दूसरी साइड का लेटरल साइड इज गॉन सर। ना डार्क रूम प्रोसीजर, अंधेरे के अंदर करने जाने वाले प्रोसीजर, ठीक है, अंधेरे में, ठीक है, डार्क रूम प्रोसीजर के अंदर। रेटिनोस्कोपी, टेस्ट ऑफ रिफ्रैक्टिव एरर, पिन होल डायमीटर, दिस इज रेटिनोस्कोप, पिन होल डायमीटर इज 1 millimeter and distance from which is designed 1 millimeter. Now different type of retinoscopic examination we do, sir. Distant direct ophthalmoscopy, distant direct and indirect, distant direct and indirect. This is how we are dividing it into, sir. Sir, remember, distant direct distance is 25. Normal eye, you will see red glow. Retinal detachment, gray glow. Vitreous hemorrhage, sir, no glow. And cataract and opacity, very important topic for the exam. नॉर्मल आंख आपको कैसे दिखेगी? लाल लाल दिखेगी सर। डिटैचमेंट हो जाएगा तो ग्रे ग्रे दिखेगी। विट्रस हीमोरेज आएगा तो कोई ग्लो नहीं दिखेगा। और अगर कैटरैक्ट है या ओपेसिटी है तो ब्लैक ग्लो देखने मिलेगा। क्या देखने मिलेगा? ब्लैक ग्लो देखने मिलेगा। ठीक है, चलिए डायरेक्ट ऑप्थेल्मोस्कोपी, डिस्टेंट डायरेक्ट सर, द डिस्टेंस इज नॉट फिक्स्ड, द डिस्टेंस इज नॉट फिक्स्ड. Now quality is virtual, erect and magnified, and magnification is 15x. Now indirect, the distance depend on the length of the arm of a doctor. ठीक है, चलो, distance is arm of a doctor, magnification is 5x, quality is real, inverted and magnified, real, inverted and magnified. This completes our third subject, my dear friends. My dear friends, let's talk about the next subject and that is going to be the anesthesiology, pre-op orders. हर एक सर्जरी से पहले pre-op orders बहुत ज़्यादा ज़रूरी होते हैं. Written and informed consent आज ही पढ़ा. NPO कब कब रखना है, that is also very important. सर, क्लियर फ्लूइड 2 घंटे पहले, ब्रेस्ट मिल्क 4 घंटे पहले और गाय का दूध 6 घंटे पहले. गाय के दूध के साथ कॉफ़ी वगैरह ये सारी 6 घंटे पहले. अंडा, डोसा, चावल 6 घंटे पहले और मीट, मुर्गा, समोसा 8 घंटे पहले. फॉर अ सेफर साइड इन द हॉस्पिटल प्रैक्टिस वी डू 8 आवर्स पहले. ठीक है, 8 आवर पहले सर. ठीक है, सेफेस्ट वन. ठीक है, सेफेस्ट वन सर. चलिए, नाउ ड्रग दैट नीड टू बी स्टॉप प्रायर टू द सर्जरी. ऐसे कौन से इंपॉर्टेंट ड्रग्स हैं जो सर्जरी से पहले हमें रोकने होते हैं? व्हाट आर दोज ड्रग्स सर? सबसे पहले एनपीयू की गाइडलाइन आपको पता चल गई. क्लियर फ्लूइड होगा अगर, ठीक है, क्लियर फ्लूइड होगा अगर, तो पानी वगैरह ये सारी चीज़ें, कोकोनट वाटर आ जाएगा इसके अंदर, ग्रीन टी आ जाएगा, है ना, जूसेस आ जाएंगे. फिर ब्रेस्ट मिल्क 4 घंटे और फॉर्मुलेटेड मिल्क आपका 6 घंटे. ठीक है, और आपका जो मीट, मुर्गा, अंडा वगैरह है, आपका पिज़्ज़ा है, आपका डोनट है, ये सारी गंदी गंदी चीज़ें जो है 8 घंटे. ठीक है, चलो जी. Now sir, drug that need to be stopped prior to the surgery. First of all, oral antihypertensive drug. You can continue till the day of surgery except 𝗚𝚎𝚲s and 𝗚𝗵𝚋s. 𝗚𝚎𝚲s and 𝗚𝚗𝚋s on the day of surgery you don't have to give. First thing, oral hypoglycemic drug. ठीक है, OHS. ठीक है. Now, minor surgeries omit the last dose. Major surgeries omit the last dose and shift that patient to insulin to maintain the blood glucose level. To maintain the blood glucose level, sir. Blood glucose level, sir. Then third is antipsychotic, antidepressant and antiepileptic. You can continue till the last day of surgery except TCA, tricyclic acid. Stop 3 weeks prior to surgery. See, 3 alphabets are coming in this, 1, 2 and 3. So stop 3 weeks prior to the surgery. Lithium you should stop 24 hours prior to the surgery. So yes, antipsychotic drug, depressant and the antiepileptics you can give till the day of surgery, but you need to stop TCA, that is 3 weeks prior to the surgery, lithium 24 hours prior to the surgery, sir. Now thyroid medication you can continue till the last day of surgery. Surgery के दिन तक भी आप उसको continue कर सकते हैं. Anticoagulants, my dear friends, aspirin continue till the day of surgery. Clopidogrel 4, C is sounding like a 4, so 4 से 5 दिन prior to the surgery. Yes, it is important. Low molecular weight heparin 12 hours prior to the surgery. 12 hours prior to the surgery. ठीक है, low molecular weight heparin हमें लो लगता है दिन में, रात में 12 बजे, तो 12 घंटे पहले. Unfractionated heparin 6 hours prior to surgery. तो लो मॉलिकुलर 12 घंटे, अनफ्रैक्शनेटेड जो है वो 6 घंटे पहले. वारफेरिन एटलीस्ट 3 to 4 days प्रायर टू द सर्जरी. 3-4 लोग मिलकर लड़ाई लड़ रहे होते हैं, तो एटलीस्ट 3 to 4 days प्रायर टू द सर्जरी we need to stop this. We need to stop this 3 to 4 days prior to the surgery. So complete, done. So these are the drugs which we need to stop prior to the surgery. Okay. Now my first question to all of you: the antihypertensive which we do not give on the day of surgery are 𝗲𝗃s and 𝗃𝗃s. 𝗲𝗃s and 𝗃𝗃s. Sir, thyroid medication we can give till the day of surgery, yes or no? Thyroid medication, yes, we should continue. My next question is, lithium need to be stopped when before surgery? Lithium need to be stopped when before the surgery? Lithium need to be stopped when before the surgery? Lithium 24. Sir, low molecular weight heparin, लो मॉलिक्यूलर वेट हेपारिन कब स्टॉप करना होता है? लो मॉलिक्यूलर वेट हेपारिन कब स्टॉप करना होता है? लो मॉलिक्यूलर वेट हेपारिन, लो मॉलिक्यूलर वेट हेपारिन, यस. लो मॉलिक्यूलर 12 लो मॉलिक्यूलर वेट हेपारिन 12 hours prior to the surgery. Sir, unfractionated heparin, when we need to stop unfractionated heparin? 6 hours prior to the surgery. 6 hours prior to the surgery.